about sex after 50s. Okay, the contents of my topic, today's topic actually about the importance of sexual health, sexual response model, what are the factors affecting sexuality, and the main thing actually about sexual health after menopause. Okay, the contents of my today's topic about sexual health, and then it's nice for all the audience to know a little bit what are the sexual response model and what are the factors that affect the sexuality after the age of more than 50s, or maybe younger in the case of premature ovarian failure, premature ovarian insufficiency, and about the sexual health after menopause. And I will go deeper on the female sexual dysfunction, about definition, prevalence, the effects of menopause, patient assessment, and also the treatment option. WHO quoted that sexuality is an integral part of the personality of everyone, either a man, a woman, and a child. It is a basic needs, an aspect of being human that cannot be separated from other aspects of life. The sexuality problems. There are only few studies on female age-related sexuality, especially among the elderly, and also because of a cultural bias against the older female sexuality. Is it true? And because in our culture in Malaysia, it's quite a taboo to discuss about sex, and especially among the older women, and especially among the aging female population. And also because of women's own unwillingness to discuss the problem with their sexual problem, and so difficulties in diagnosing female sexual dysfunction or the female sexual response. However, there are several studies suggest a decline in sexual interest during menopause. Okay. I've got one quiz actually I would like to ask, but only one person to answer only. Okay. What is the most important sexual organ for a man or a woman? And the prize will be the novel, my novel actually, about Mengejar Zuriat. The novel that was published by Dewan Bahasa and Pustaka last year in 2017 is written a book together with my patient, infertility patient that have been married for more than 10 years. So we share the problem and we come up with a novel about Mengejar Zuriat. Okay, who would like to answer the question? And the prize will be the novel. Dr. Rizwan? What is the most important sexual organ? What is the most important sexual organ? Yes? Yeah? Yes, very good. You can get Nobel afterwards. Okay, thank you. It's a very simple question. Okay, so the brain. Actually, the brain is the most important organ actually. So this brain actually is a brain from a male brain and so a female brain. Like from here we can see that the most important, there is a difference between the male brain and female brain. The male brain, the most important actually, the most prominent actually, the sex. I mean the women, sex. For the men, but for the female actually, it's a headache generator. But maybe for headache generator you can similarize or assume this is more of my commitment. That's why a woman, they try to be empowered and they try to be committed to their responsibility as a wife. There's a difference between the male brain and also a female brain. Okay, that's why in 2016 we come out with the books and a man, because their main problem is about sex, and they will go to the hospital to see a doctor, because in USM we managed to set up a men's health clinic in 2007, whereby the clinic is conducted by the male specialists that specialize in men's health, and also the medical officer also a male, and the nurses also a male nurse, and the attendants also a male. So they conducted a few cases every week, once a week, sometimes referral from other hospital also, when the man got a problem. Look like when this type of men, when they go and see the specialist, when they are all men, they will would like to share everything with the doctors. That's why we come out with a book actually, together with my husband, Prof. Saiful. The first book about sexual problem is masalah seksual lelaki dalam kesejahteraan suami isteri, because we know that this is the most important problem that we need to encounter actually. Sometimes we are also very shy to ask about the couple about sexual problem, because sometimes patient cakap doktor ni busybody kan, okay, but beware of that actually. You need to know also that the man, the problem can start a little bit earlier compared to a female, not just after 50s or after menopause. Sometimes can be earlier, before the 40s. That's why it's also important to know about the man's problem. Okay, before I go further, I would like to just discuss a little bit about sexual response model. That is a common model that was proposed by Master and Johnson. Is a linear model, Kaplan model of sexual response, and also the Besson model for female sexual response. Okay, this slide shows that this actually model is a sexual response that was proposed by Masters and Johnson, that we call as a linear model in 1966 actually, I mean about 52 years ago. That they start with the excitement, and then the plateau. They have 4 stages, and the plateau, and then they will jump when they are climax, orgasm, and after that resolution. Look like they are already satisfied. So look like when they are resolution, they are, for men actually they are already in a phase of resolution or recovery phase, or already satisfaction phase. Look like they already karam and dibuai mimpi yang indah, but maybe not for female. Okay, and later in 1979 actually, Helen Singer Kaplan added a new theory, that they add one more actually, the desire. Just now we start with the excitement, plateau, orgasm, and resolution, but now they add one more theory. They put desire, but they condense actually the 4 phases of the sexual response into 3 phases only. That means desire, excitement, and the orgasm. No more resolution. Look like the women and the men is different. From this slide we can see that the men, they are very simple. They have everything 3 in 1, but not for the female. When they want to travel, they need to bring everything actually. Like they are very complicated. Okay, from the previous story, from the 2 previous story about sexual response, from the Master and Johnson and Kaplan, assume that men and women have similar sexual response. For sure that's not correct. That's why this theory has been criticized. Because the women may not experience all the 4 phases, like the excitement, the plateau, orgasm, and the resolution. Sometimes they may have moved from a sexual arousal, to orgasm and satisfaction without sexual desire. Look like the Kaplan theory also not correct for a female. Or they can experience desire and then later arousal and satisfaction, but most commonly not orgasm. That's why a new theory was proposed by Besson Art in 2001. This is we call as a non-linear model. Just now we got a linear model. This one is a circular model. So there is an importance of emotional intimacy. It's very important for a female, of the presence of emotional intimacy, sexual stimuli, and relationship satisfaction. So that this model acknowledges the female sexual functioning proceeds in a more complex manner. It's more complicated. So this Besson model clarifies the goal of a sexual activity for women is not necessarily orgasm. However, personal satisfaction satisfaction manifests as a physical satisfaction, as orgasm. Physical satisfaction is considered orgasm for female, and emotional satisfaction, feeling intimacy with the partner. So the sexual health of the menopausal women. So I go further for female sexual dysfunction. This female sexual dysfunction affects about 20 to 50% of women. It's quite common. It's due to multi-dimensional and multi-causal, combining biological, psychological, and interpersonal factors. And it can cause physical and emotionally distressing and socially disruptive to the women. And this female sexual dysfunction increases with the age of the women. So for the definition, there are 4 groups actually. This one is according to the International Consensus Development Conference on Female Sexual Dysfunction that was published by Besson in 2000. Put this as FSD into 4 groups. The first group is sexual desire disorder, or is due to hypoactive sexual desire disorder, HSDD, or sexual aversion disorder. The group 2 is sexual arousal disorder. The group 3, sexual orgasm disorder. And the 4 actually sexual pain disorder, can be dyspareunia, vaginismus, or other sexual pain disorders. However, to fulfill the definition for female sexual dysfunction, the symptoms should be persistent, recurrent problem with sexual response, either is a desire, orgasm, or pain that can cause distress to the women. There are also a new diagnosis. Initially, they followed the DSM-4 to diagnose a female sexual dysfunction, the 4 group that I mentioned just now. This one by the American Psychiatric Association in 1994. They put into 4 groups. However, in 2013, they upgrade the DSM-4 to DSM-5, and then they merge together these 2 groups into 1 group that they put into a female sexual interest, that means the interest, and the arousal disorder. That means the desire and the excitement, they put together. And the second group is the orgasm, and the third group is pelvic or genital pain disorder. So DSM-5, there is a changes, so define, so that they conclude that for the male sexual dysfunction, it's good that to follow the Kaplan's model. I mean the desire, the excitement, and orgasm. But for the female sexual dysfunction, it's better to use a Besson or a non-linear model or a circular model to treat the female sexual dysfunction. What are the factors influencing sexuality in women after the age of 50? Just now that for the past 2 days, I'm sure that you already learned a lot actually. There are, that means cancers also can contribute to sexual dysfunction, emotional problem, maybe because of the climatic symptom, menopausal symptom. A culture, when they are already aging, it's not nice to be sexually active. And also relationship problem, because at that time there are maybe the image also different from the shape, the body shape. Now they are apple shape or pear shape, because the body image different. Problem, maybe the partner also looks that the wife, the image also not so good already. That's why it's very important actually for the husband to know about the problem when the wife is reaching menopausal age. That in USM, we conducted a study that we put a SPY, SPY, a SPY study, that we managed to get a grant to conduct a study. Is actually a SPY is a spouse psycho-education intervention program that we recruit a husband, a spouse from a menopausal woman. We put in a group actually, so we educate them, teach them, and discuss in a small group discussion about what happened to their wife when the wife in the menopausal age. That means relationship problem, partner sexual function, the anxiety, sexual abuse, maybe domestic violence, and also the other problem that I put here that can cause sexual problem among the women. For female sexual problem, they are overlapping actually. Even though the most common actually is the desire and arousal, that the hypoactive desire disorder, no desire, poor libido, no arousal, arousal problem. This is the most common problem that can be experienced by the menopausal women. But the others can be vaginismus, orgasm difficulties, and pain, dyspareunia during penetration. This slide shows a study that was conducted among the Australian women aged 20 to 70 years old, that they looked at this function that were defined using the Sexual Function Questionnaire, SFQ, and the Female Sexual Distress Scale. They found that the most common that I mentioned just now is a hypoactive sexual desire disorder and the sexual arousal disorder. This one they put into 4 groups because they published the paper in 2008. Because the DSM-5 they merged in 2013. But this one before the DSM-5, they used the DSM-4. That's why they got 4 groups. But the most common actually is HSDD and sexual arousal disorder. HSDD and the orgasm disorder from this slide. Okay, this study is a precise study. It's a prevalence of sexual problems and sexual-related personal distress by age. That they conducted a study to look at the sexual problem, that they know that the sexual problem is increased with age, but the sex related to the sexual problem, that means the personal distress is decreasing. I think because of most of the women when they are aging, even though they are having sexual problem, they try to accept this one as the ragdoll. That means the acceptance. That's why the distress is coming down. Even though the prevalence of sexual problems are increasing when the age is also increased. What are the effects of the menopause? In the perimenopausal period, there is a dramatic fluctuation in the sex hormones. There is a change of life, that means the physical symptoms. There is empty nest syndrome, children leaving home, and they are no longer fertile. And there is a change in the body or self-image. And because of low level of estrogen and testosterone, so this one can cause reduce in libido, increase in problems of dyspareunia because of vaginal dryness, and also diminish in the sexual response. In the postmenopausal age, in the aging population, and because at that time they are having all the medical problem, general health decline, they are having all the bone problem, osteoarthritis, all the joint pain problem, and they are having also other comorbidity, like that we discussed this morning about the metabolic syndrome. They are on so many medication. That the study that we conducted among the postmenopausal women in about 2008-2010 in USM, we found that the metabolic syndrome among the postmenopausal women is about 35%. Look like they are on so many medication already at that time, and also other illness-related factors. And also they got a problem sometimes with their partners, because the partners did not understand their problem, their menopausal problem, their sexual problem. Because we conducted a study, qualitative study actually, the most important that the men's one actually is still the sex actually, the sex. Even though they are very shy, especially the wife, they are very shy to discuss with the doctors about their sexual problem. And for the hormonal causes of female sexual dysfunction, because of the lack of estrogen and menopause-related issue that was presented and in detail by Prof. Nazima just now, there is a decrease in vaginal dryness and dyspareunia, and reduce in sexual desire and arousal. And this is also maybe because of low testosterone level when they are already in the aging population. There is a cross-sectional data reported from a legitimate population-based cohort among the Australian women 45 to 55 years old that was published by Denenstein L. In 2000, mentioned that there is a reduce in sexual responsivity and reduce in sexual frequency, reduce in libido, and increase in vaginal dyspareunia and partner problems when they are in the menopausal transition. That's why in 1998, I was called and invited by the Majlis Agama Islam Kelantan in 1998. At that time, looked like the HRT is very popular at that time. However, because the usage of HRT is still quite low at that time in 1998, and according to the statistic by the Majlis Agama Islam, they found that there is increased rate of divorce rate and polygamy rate in Kelantan at that time. That's why we were called to present about the menopausal problem, because they found that the most common divorce rate and polygamy rate is among the partner when they age about 50-55 years old. That's why we were called at that time to discuss about menopause and presented about menopause problem to the imam besar at that time. And then they come up with the 4 fatwa by the imam in Kelantan in 1998. The 4 fatwa. The first fatwa, they mentioned that because at that time, this one is 1998, HRT at that time is quite popular, and that time the HRT that was available is only the Primarin. The estrogen is only Primarin. There is no Proganova, no other form of estrogen, only the Primarin. Look like Primarin is a pregnant male urine, pregnant horse urine. And then the Imam and the Mufti come up with the fatwa that there is halal to use a pregnant horse urine as one of the medication. And the second fatwa that when the women they are in the pre-menopausal age, what they got a postmortem symptom, that we prescribe them as with the cyclical HRT. When they have menses, that one is considered menses. The third fatwa, when they are on patch, estradiol, on patch, there is prohibited, there is not kalis air, there is one to get to take hadas besar, they need to remove the patch. And the fourth fatwa actually mentioned if they want to be on HRT, they need to get permission from the husband. Okay. This slide shows that there is an indirect effects of menopausal complaints on sexuality. Because the women in the either in the perimenopausal age, they are having hot flushes and insomnia. They are having all the other physical problems like fatigue, and they are also got psychological problems, depressed mood. These are all that can give negative effects on the sexuality. This slide shows that like this one is actually a Kaplan model in 1997. They start with the motivation, arousal and orgasm. From here we can see there is a delay in the vaginal vessel congestion and reduced lubrication and vaginal dryness and painful intercourse. And also there is an increase in the plateau, the duration between the phase of the sexual response for the plateau. However, the orgasmic response is the same, and the length of the refractory period is also the same. So the patient assessment, it's good that for us to be prepared and need to ask the question to the patient, are you sexually active? Are you having any sexual difficulties or problem at this time? Or these are all the questions that maybe you need to ask in a private manner. Do you have any concern about your sexual health and the others? Okay, and it's good that you need to ask also either they are on other medication that can affect their sexual function. and the symptom, vaginal symptom, about dryness, itching, dyspareunia, and the others. And the treatment option, that we can use the PLISSIT model. PLISSIT is a PLISSIT model. First, that you start with the permission when you want to discuss something that is very private about their sexual problem, and then you need to give a limited information, specific suggestion, and then you can offer intensive therapy. These are the flow chart that you can use actually when the women with female sexual dysfunction, a basic evaluation about their sexual history, about their medical history, about their psychosocial history, and then either when they have other problem like depression or maybe abuse or other endocrine problem, maybe you need to refer the patient to a specific expert, and then it's good to treat or educate both the patient and their spouse, their partner, and give treatment. Either treatment can be a counseling or can be a sex therapy or hormonal therapy, and then we evaluate during the follow-up. So the treatment actually is a basic sexual counseling, lifestyle changes, psychosexual therapy, either it's individual or both for the husband and wife, and also additional counseling of the partner is also recommended. And you might offer the patient to be given hormone therapy in women with sex hormone deficiency, either estrogen or with a tibolone, or non-hormonal pharmacological treatment. And also you need to be aware, try to look for either they are having also the depression problem or not. So the estrogen, either it's a local or systemic, can improve lubrication, decrease the vaginal atrophy symptoms, and also some study mentioned increase the desire and enjoyment. For tibolone, estrogenic, because they got the estrogenic and also androgenic effects, so they can be good for the sexual well-being. It's more effective than the oral estrogen progestogen therapy or estrogen therapy in some respect, especially for arousal, desire, and also sexual satisfaction. And also tibolone positively affects mood and quality of life, and sometimes maybe you can add also the low dose of testosterone to increase the desire and satisfaction. Most study mention that there is improvement when you put the patient on estrogen, improvement in the vaginal blood flow, vaginal lubrication, improve the sexual desire, and also the clitoral sensation. What about the non-hormonal treatment? There are also other non-hormonal treatment that you can offer to the patient. You can give also Viagra, sildenafil. Even though sometimes maybe the HRT may be enough already, but there is a role that from the other study mentioned that there is a role for sildenafil and other drugs like prostadil, apomorphine, and herbal treatment, and also natural products. Like from our study that we did, we give the patient to look for the female sexual function index, that we give a honey cocktail, a combination of honey, bee bread, and the royal jelly for the sexual dysfunction. This is my last slide. It's a take-home message that female sexual dysfunction is common among the perimenopausal women because of lack of estrogen, and female sexual dysfunction tend to be overlapping to each other, and it's a new problem. Maybe and it's important for us as a doctors to be aware that we need to counsel the patient also about the sexual problem, and we need to manage their sexual problems. And it's nice to use the PLISSIT model for the management of female sexual dysfunction. However, there are also many options of treatment available. Thank you.